Hi, my name is Mehul Trivedi. I'm a first-year intern at UC San Diego, and the title of my vignette is Valproic Acid Toxicity, an Uncommon but Dangerous Syndrome. So for a little bit of background, valproic acid is a commonly used medication, and it's been used for over 40 years, but despite this, the mechanisms of its action are not commonly or well understood. It's thought that by blocking voltage-gated sodium channels, it increases brain levels of GABA, thereby enacting its anticonvulsant and antimanic effects. Because its toxidrome is not commonly encountered, principles behind its management are not terribly well known and are largely derived from limited case series. Our clinical presentation was a 36-year-old man with a past medical history of bipolar disorder presenting to the ED after ingestion of 46 grams of valproate and 23 milligrams of risperidone. His vital signs were significant for a blood pressure of 100/56, a heart rate of 125, and a respiratory rate of 12. Physical exam showed a somnolent man, minimally responsive to noxious stimuli with labored breathing. He was able to protect his airway, and he was satting well on room air. Labs were significant for a serum valproate level of 650 micrograms per ml. A therapeutic range is typically anywhere from 50 to 120. AST was 52, ALT was 85, and the serum ammonia level was 38. This patient's hospital course was initiated with a toxicology consult. The decision was made to initiate levocarnitine treatment to protect against hepatotoxicity. A contingency plan was to initiate dialysis should valproate levels reach 850 micrograms per ml. Looking at the top graph, we can see that this patient's valproate levels peaked on the day of admission at 770 and then steadily trended down. We were looking at the bottom graph, transaminase levels also peaked prior to the initiation of levocarnitine treatment before steadily trending down after as well. Serial neuro exams showed a progressive improvement throughout the course of hospitalization with a return to baseline within 2 days, at which time the patient was discharged to inpatient psychiatry. So valproic acid is primarily metabolized through the liver, but it undergoes beta and omega fatty acid oxidation. This is the primary means by which toxic metabolites are created. In cases of valproic acid overdose, stores of carnitine are depleted, thereby limiting the amount of beta oxidation that can go on, given that carnitine is an essential cofactor. This leads to the shunting of valproic acid metabolism to omega oxidation, which leads to the creation of more toxic metabolites. Levocarnitine administration can increase urinary excretion of valproic acid, thereby limiting the accumulation of these toxic metabolites. Adverse outcomes of valproic toxicity include metabolic acidosis, hepatotoxicity, cerebral edema, as well as coma. These are typically associated with levels greater than 850. That's why we were using that, and that's why that's recommended as the level above which to initiate dialysis. So take-home points in this case are that monitoring of serum valproate levels, as well as administration of supplemental levocarnitine and just supportive management are cornerstones of treatment for valproic acid toxicity. Even though this is not a very commonly seen toxidrome, given the abundance with which we use valproic acid, it is something that I feel clinicians should be aware of how to manage. Prompt recognition of some of the symptoms and side effects of this toxicity can vastly improve patient outcomes. Thank you so much for listening to my presentation, and I hope you all have a great day.